pleased to be able to present Jay Shavadia, who's one of the fellows, the research fellows here at the DCRI. He completed his cardiology and interventional cardiology training at Alberta with our friends there at Canadian CVC, Canadian Vigor Center, Centra, the way you guys spell it. And he is here as a DCRI research fellow for 2 years. He's going to be talking to us today about STEMI reperfusion strategies and the PCI toolbox. So thank you very much.
Thanks, Jen. Thank you very much for giving me this opportunity to present to you today. And this talk is really, over the next 30 to 40 minutes, highlighted or aims to highlight the differences in reperfusion strategies in STEMI. And then the second part of the talk essentially shows you some of the mechanics of PCI and some of the tools and techniques that are commonly utilized in PCI in general, and there's a significant overlap with PCI in STEMI. And so the fundamental aspect in the treatment of STEMI is to rapidly recanalize the completely occluded artery. And that statement holds true about 90% of the time, depending on which data you look at. About 10% of the times, more commonly in registry data, seems to suggest that patients who present with a STEMI, when they come for primary PCI, have pre-PCI TIMI3 flow. So the artery spontaneously broke down that clot, and although at the time of the angiogram there may be residual thrombus, there is at least normal flow going down the artery. And usually, STEMI is preceded by plaque rupture, and again, that statement holds true about 95% of the times. Occasionally, we do find an artery that's completely occluded because a clot moved from somewhere else from the heart, so from the left atrium or the left ventricle or somewhere on the valve, and then embolized down the coronary artery and then completely occluded it. For the purpose of this talk, we'll presume that we're dealing with a completely occluded artery and that the underlying reason why this patient presented is from plaque rupture. And so when plaques rupture, they expose the underlying thrombogenic material to blood. That material is highly thrombogenic. It activates platelets. Platelets rapidly organize, form a clot, and the artery is completely occluded. And that's usually what heralds symptom onset. And so this diagrams you may have seen before, I think are key in highlighting the differences in STEMI and non-STEMI. And the diagram on the left shows a coronary artery. This pointer works, but so this was the lumen. This was the lumen of the coronary artery there. That's the cap of the plaque, and that was the underlying plaque. And for reasons we don't really know why, this plaques rupture, and so the plaque ruptured right there, exposed this highly thrombogenic material that was within the plaque to the blood. Platelets organized and rapidly formed a clot, completely occluding this artery. And usually when this happens, the hallmark is on the ECG. This is a normal ECG, and we'll focus on the ST segment, which is right here. When the artery is completely occluded, the ST segments elevate, and when they meet certain thresholds, a diagnosis of STEMI is made. On the other end of the spectrum is a coronary artery here, similarly has a plaque here, a fibrous cap, the cap ruptures, and a clot forms. But for some reason, the body's endogenous ability to break down clot supersedes the ability to form clot. And so despite clot formation, there's really a patent lumen allowing blood to flow despite plaque rupture and clot formation. So really highlighting the difference between STEMI, which is a completely occluded artery, and non-STEMI, which truly is underlined by plaque rupture, but really does not result in complete coronary occlusion. And so this is a still picture of a right coronary artery. And usually, this is the catheter. We inject dye. The right coronary artery is a C-shaped artery that divides terminally into two, a posterior descending and a posterior lateral. And here is an angiogram of a patient who had an inferior STEMI and clearly shows that the artery is occluded somewhere in the middle here, usually by thrombus. And this is the left system. Again, this is a catheter that we use to inject into the left main. So this is the left main that divides into three. An artery that runs down the back of the heart, which is a circumflex, which has branches denoted as obtuse marginals. An artery that runs in the middle, that's the ramus. And this may or may not be there. And an artery that runs down the front of the heart, which is the left anterior descending, and branches off, which are diagonals. In this patient who presented with an anterior STEMI, very similar view, the left main, then the left anterior descending is occluded right there, and usually occluded full of thrombus. And in contradiction to the STEMI is this patient with a non-STEMI, and again here a left coronary artery that shows a tight, really tight stenosis, usually preceded by plaque rupture, but past that stenosis is normal flow going down both branches. So clearly showing us that in STEMI, the artery is completely occluded, while in non-STEMI, there's usually normal flow going past that narrowing. So I'm going to show you this case, and the purpose of this case is really to highlight the differences in reperfusion strategies in STEMI. And so this is an ECG of a 63-year-old male who in the winter called 911 at about 9:15 in the morning with chest pressure that had started about 45 or 50 minutes prior. EMS arrives at about 9:27, and so that's 67 minutes from symptom onset. I really want you to take away some of these times and why these times from symptom onset to first medical contact are important, and I'll highlight those in the next few slides. Patient's past medical history includes hypertension, he's hemodynamically stable, gets aspirin, clopidogrel, and unfractionated heparin. The patient's from a rural community, and the nearest PCI-capable center is about 110 minutes away. And the question is, how do we reperfuse this patient? Should we administer fibrinolysis, or should we bring him over for primary PCI? And so that's an important question, really not so as much here, where there are about 25 primary PCI centers in North Carolina. Patients live within 60 minutes of a PCI-capable center, but in areas of the world where times like this patients are significantly far away from a PCI-capable center, how do we effectively reperfuse these patients? And our understanding of the association between the infarct size and the duration during which this artery is occluded comes from these hallmark clinical experiments that were actually performed here by Reimer and Jennings at the pathology department. And what they did is they occluded the coronary arteries of dog models. And when the artery was occluded for 40 minutes, they found that there was a really small area of infarct and a fairly smaller sized area of ischemia. But almost all the myocardium was viable. When the artery was occluded for 3 hours, they noted that the infarct size had significantly increased, but there was still a fair amount of viable myocardium. Beyond 3 hours, and certainly beyond 6 hours, the infarct size is almost evolved, and there's barely any viability left. And so to translate that into clinical practice is this diagram by Dr. Gersh. And this is probably the key slide in this presentation. And what he highlights is on the x-axis is time from symptom onset to reperfusion. And on the y-axis is mortality, and the area under this curve is the extent of myocardial salvage. And what he notes is that after about 1 hour, that's after about 60 minutes of symptom onset, patients get into this part of the curve where every increase in delay in reperfusion results in a significant amount of myocardial that's lost. Sorry. And so the guidelines actually reflect on this and say all eligible STEMI patients should receive reperfusion, and that myocardial salvage is actually time dependent, and that the total ischemic time is probably the single most important determinant of STEMI outcomes. Primary PCI is probably the preferred reperfusion strategy, but if it can be delivered in a timely manner. And that's usually 90 minutes from symptom onset, 90 minutes from first medical contact, and 120 minutes for transfers. And fibrinolysis for STEMI in whom reperfusion delays are anticipated. In this work that was done here by Dr. Jolis, they noted that in reality, reperfusion delays are expected. And that by organizing systems of care, by using common protocols for diagnosis and treatment of STEMI, that across all modes of STEMI presentation, so whether it's direct STEMI, patients coming by EMS, or by hospital transfer, using common protocols for diagnosis and treatment led to significant improvement in times to treatment across the quarters that they evaluated. However, we acknowledge that about 30 to 40% of these patients still did not meet guideline-mandated times to treatment. And this, is another example of similar work from the Mission Lifeline Registry. And they noted that in about 14,000 patients, more than 1/3 of STEMI patients transferred for primary PCI did not achieve first medical contact device time under 120 minutes, despite having transfer times of less than 60 minutes. And in reality, and this is work by Amit Vora, and he noted that the median drive time for patients who are being transferred from a non-PCI capable center to a PCI capable center is about 57 minutes. And even in patients who had a drive time of less than 30 minutes, only 2/3 met their first door to balloon time of less than 120 minutes. And in patients who we anticipated are going to be delayed, so who had an estimated drive time of greater than 60 minutes, we administered thrombolysis in only 52% of those patients. And the remaining patients who are actually being transferred for primary PCI. And in those transferred for primary PCI, only about 1/3 met their guideline-mandated time. So really highlighting an opportunity for improvement in times to reperfusion. So in reality, when patients present, symptom onset to first medical contact is usually about 60 minutes. And this is true across the United States and in non-US centers. From first medical contact, when EMS arrives, get into the house, evaluate the patient, get an ECG, transmit the ECG, and get a diagnosis that, yes, truly, this is a STEMI, takes another 30 minutes. From diagnosis, the drive time to a PCI-capable center will be another 60 minutes. And when patients arrive to a PCI-capable center, it takes at least 30 minutes for us to get the artery open. And so the total ischemic time is usually, from symptom onset, about 3 hours. And if you may say that, yeah, well, this is from a registry, delays are anticipated. And this is a table that I've taken off the STREAM trial, which was a randomized controlled trial within well-established networks of care. And what I want to focus on is that symptom onset to the start of primary PCI within a randomized setting, 178 minutes. So really consistent that it usually takes about 3 hours from symptom onset to get that artery open. And I want you to reflect that on the graph that Dr. Gersh had put, where patients are on that steep part of the curve, and every increase in reperfusion delay results in a significant amount of myocardium that's at risk.
And the fibrinolysis is shorter because those patients are getting it in the
So they were getting it on the field.
yeah.
And so in areas of the world where 4 months out of 12 the weather's like this on the left, on the right, and in a province like Alberta, which is about 660,000 kilometers squared, there are 2 or 3 primary PCI centers, 2 in Edmonton and 1 in Calgary. A patient presents with a STEMI up in Fort Nelson, the interior of British Columbia. It takes them at least 2 hours to fly them to Edmonton if you were to do primary PCI. So really, how do we improve reperfusion in a patient or in settings like these 2? And so within Alberta, the system is patient presents with a STEMI, they call 911, EMS gets to their house, and ECG is performed. The ECG is electronically transmitted to an on-call cardiologist who reads the ECG, communicates with the EMS staff on the ground, says, yes, this is a STEMI. How long is it going to take you to get to Edmonton? If the transport time is going to be greater than 1 hour, then the EMS administers thrombolysis on the field. and then transfers that patient to a PCI-capable center. When they arrive, about an hour to 2 hours later, we assess for perfusion. If the patient did not reperfuse, or if the patient reperfused, they undergo scheduled PCI about 3 to 24 hours later. If they did not reperfuse, they undergo rescue PCI on arrival. Only if their transport time is under 1 hour that they come in for primary PCI. And truly, we believe that is one strategy where we could move patients from point C to point D by trying to reduce the ischemic time and increasing the amount of myocardial salvage in patients with STEMI. And this is one strategy. Within the STREAM trial, which essentially evaluated that exact population, so a STEMI, within 3 hours of symptom onset, anticipated time to cath of more than 1 hour, were then randomized to lysis or primary PCI. And they found that on their primary endpoint, really no difference, which was a composite of death, shock, heart failure, and reinfarction at 30 days. And really, it's hard to show a mortality difference in patients who are presenting early and treated this quickly. And so the suggestion was, could we reduce downstream effects like heart failure or shock? Really, we cannot reduce mortality because we're treating them this quickly. But since we're saving myocardium, could we potentially reduce heart failure and shock? And so within STREAM, they actually just put these two heart failure and shock numbers together in a 2x2 table. And what they found was that, and this is just hypothesis generating, that when we put heart failure and shock together, the differences between these two groups become statistically significant in favor of lysis. And so the key points here are that time from first medical contact to reperfusion is really the only objective way we can measure. I mean, we can't really measure when patients say, yeah, the symptoms started at this time, but really that's not objective. And the reason why we record first medical contact to device time is because that's the only objective time. But the clock really started ticking with symptom onset. And that is usually 60 minutes have usually elapsed between that time to first medical contact. Primary PCI is the preferred reperfusion modality if it can be delivered in a timely manner. But if delays are anticipated, then a pharmacoinvasive strategy is a valid alternative. And so we're going to move into the second part of the talk, kind of talk about the mechanics of primary PCI. Sorry. And so for us to perform primary PCI, we have to get arterial access, take some pictures, confirm that the artery is occluded, and then slip a very fine wire, which is probably the most important part of this procedure. A wire is kind of thinner than our hair. It slips through that thrombotic lesion. Once we get across, then it acts like a bridge over which we can deliver balloons and stents. We inflate a balloon to gently squish that thrombus against the arterial wall and open a channel, and then deploy a stent to keep that artery open. And so there are two common access sites that we use, radial or femoral. Radial is what is now our default, and we use it more than 90% of the times for primary PCI. It's a smaller artery, and therefore it's technically more challenging for the operator compared to the femoral, which is a larger artery and it's quicker to get into. But because it's a larger artery, then it's associated with significantly more bleeding. Patients are able to ambulate immediately for radial access compared to about 4 to 6 hours later for femoral access. We cannot put in mechanical circulatory support radially. Femoral is currently the only way. And there's a lot of data. It's supported by 4 randomized trials, and this is just observational data that I show from a different setting. So in the United Kingdom, radial versus femoral, again, 30-day mortality, both for stable and ACS settings, in favor of radial compared to femoral, and predominantly being driven by less bleeds and less access site complications. So once we get arterial access, we use a catheter, which is about 100 centimeters long, comes in different sizes, in different shapes. This engages the left coronary artery here. Down here is the right coronary artery. We then slip a wire down the coronary artery. I don't think this is showing, but that fine wire goes past. We then use a balloon, which has two radio-opaque markers. This is deflated. This is what it looks like when it's inflated. Once the balloon gets across the lesion, we inflate, squish that thrombus, and then deploy a stent, which is essentially crimped on a balloon. And then we take that balloon out, and the stent remains deployed. And we obviously work from outside. Essentially, it's like a video game, where you're able to kind of see on a screen what you're doing. I mean, everything is radio opaque, so you're able to see, but essentially we're working from outside. It's a beat-by-beat monitor of blood pressure, and so you're able to tell, when the patient starts to crash, you're able to tell fairly quickly. And so this is what an uninflated balloon looks like. I'm not sure you're able to see down here, but that's the radio opaque part of the wire down here. And then that's what the uninflated balloon looks like with the two markers. This is what it looks like when it's inflated. And this video won't play, but this essentially depicts what a stent looks like. So stents were introduced late in the 90s. Essentially, what happened is when they did balloon angioplasty prior, they used to go in, inflate the balloon, deflate, and then come out. But then they realized that a few hours later, the vessel acutely recoiled, or in the night there was abrupt vessel closure, and these patients had to go for emergency surgery. And so to keep that vessel open, then stents were developed, and they essentially act as a scaffold to keep the artery open, and usually tack up any tears that are associated with ballooning. And this is what a stent looks like. It's made of cobalt chromium. There are some stainless steel stents, but majority are cobalt chromium. And so when we deploy a stent in an artery, the artery generally forms a thin layer, essentially like our veins. So we're able to see the vein, but we're not able to touch it. So the artery similarly forms kind of a skin over the stent and heals that stent. And so over time, we really don't see, or the stent struts are really not exposed to the blood. But you could have situations where the artery wall repairs or proliferates excessively and narrows down the stent significantly. So here you see this is what normal looks like. This is what in-stent restenosis looks like. Occasionally, though, the body may fail to form that skin over that stent, and stent struts are left hanging, exposed to blood. And that's not a good thing, because once we stop dual antiplatelet therapy, then the metal sticking out of the blood is a risk factor for clot formation. So the arteries the stent could easily clot off. And so this is what happens when we put a bare metal stent in. It gets endothelialized very quickly within 4 weeks. No stent struts are exposed. Hence, the need for dual antiplatelet therapy is usually about 4 weeks. However, in bare metal stents, there's usually arterial wall injury, there's smooth muscle cell proliferation, and a higher risk of in-stent restenosis. So what people thought is, why don't we put a drug, an anti-cancer drug, that prevents these smooth muscle cells from proliferating and preventing this risk of restenosis. And so drug-eluting stents were developed. Essentially, it's a metal there. The red is a polymer, and the blue is the drug. And the drug gets released about 80% over the next 3 to 6 months once the stent's deployed, and then the polymer gets degraded. But what was realized is that the polymer actually delays the endothelialization of these stent struts. The struts continue to be exposed to the blood for a longer period of time, and this increases the risk of stent thrombosis once DAPT is discontinued. So when we put in drug-eluting stents, the need for DAPT is much longer, almost up to about a year. The other adjuncts that we use are aspiration thrombectomy. And so this is essentially a tube which has two holes. This goes over the wire. And then on the other end is a syringe that we essentially pull to vacuum and then deploy this whole device into the coronary artery. Once it's down the artery, then we release this vacuum and blood starts getting sucked into this hole. With it comes clot, and usually we'd aspirate stuff like this. What was seen is that it reduces thrombus burden, it does improve the indices of reperfusion. There was a mortality benefit that was noted in one trial, the TAPAS trial, and based on that mortality reduction, guidelines recommended a class 2A for routine use in STEMI. However, a follow-up trial, the TASTE trial, did not find any benefit. In fact, they found that there were potential risks that when we put this thing down, we could injure the artery wall, we could induce tears within the artery, and we could potentially embolize this thrombus, which could result in stroke. So you could imagine thrombus sticking out here. When we remove this device out, thrombus could essentially fly off and give you a stroke. And that's exactly what they found in total, which was a 10,000 patient trial. No difference in their primary endpoint, but a significant difference in stroke. And this whole stroke issue in total was debatable because really they didn't see an early spike and then curves starting to separate. The curves continue to diverge even 6 months past the procedure. So really, this may not be related to the procedure itself, but because of this hazard of stroke, the recommendation was downgraded to class 3 for routine use. And so what's the current role for thrombectomy? This may not play. So we essentially use it for bailout. This was a patient that essentially came in for stable angina, had significant stenosis here and further down here. Got a stent, multiple stents, looks fairly good after the procedure. She went outside in the recovery area and we realized that her heparin that was given in the IV line had tissued, so really all the heparin went subcutaneously. She essentially didn't receive any heparin for the procedure, and her stent thrombosed. So this is what a thrombosed stent kind of looks like. You can see all this bubble-like material within the stent. And so in situations like this where we know that the procedure was fine, we know what the culprit for the stent thrombosis is, aspiration thrombectomy may play a role in situations like this where you're able to suck out some of this clot. And so we generally use it for bailout only, and that's in about 5 to 7% of the time. What are the other imaging adjuncts that we could use? We use imaging essentially to tell, when it's difficult to tell on the angiogram what exactly is going on within the artery. And so if there's indeterminate stenosis or whether there's some haziness in the artery, we're not really sure what's happening. We deploy a stent and something really doesn't look right at the edge. Is it a tear within the edge, or a previously deployed stent has re-stenosed or has thrombosed and we need to understand why? Or we deploy a stent in very high-risk anatomy like the left main, where we really need to be certain that the stent is fully opposed to the vessel wall, because if it's not, then blood could flow behind the stent and could be a recipe for stent thrombosis. And if that occurs in the left main, then that's almost universally fatal. And so intravascular ultrasound is one modality that could be used. And on the left is a normal coronary artery. And so this is the artery wall, a very thin layer. Then there's a muscle, and then the outer layer, which is exactly what we see here. The thin layer that's bright, and the muscle that's the dark layer in between, and then the most bright layer is the layer outside. And when the arteries are diseased, they usually narrow down. And so you see in here, that's normal lumen, and this is all plaque, essentially cholesterol buildup. And so this patient comes in for an angiogram, and this is what the angiogram looks like. We're not really sure, is this 60%? Is this 70%? Is this 90% narrowed? Does this need to be fixed with a stent? Does it not? And so we put a camera down essentially to measure how thick the artery or how big the artery lumen is, and you realize that then this gray is kind of normal, and you realize this gray area here is very small. So the normal segment is essentially very small. This is a very significant stenosis that essentially needs to be stented. So this is one area where we could use imaging where the degree of stenosis is really indeterminate. And the other area, like I said, is stent malapposition. And so these bright specks are stent struts. And you see here, they're really not opposed against the wall. And this could be a recipe for stent thrombosis. And so they went back and ballooned this out, essentially normalized that area. OCT is the other imaging modality, and there is significant overlap between OCT and IVUS. Both have their indications, but we prefer to use this essentially because of the clarity of the pictures, and it's easier to see. And so here you see these dots. Essentially, that's stent struts. You can see the shadow behind. And here we realize that really the stent is not opposed against the wall. There's a gap. And this could be a potential recipe for either thrombosis or later restenosis, and that this needs to be modified with more ballooning. Here we see this artery wall. You can see the lining of the artery, and then suddenly there's a break. And so this is a tear within the artery wall, and there's a lot of blood in here. And so this is a dissection essentially. So sometimes when we see this on an angiogram, we're really not sure what's happening. We're seeing some hazy thing, but when we image that, it becomes really clear. And this is what thrombus looks like in the artery wall. So again, like I said, sometimes you see some haziness. You're not sure, is it a tear, is it thrombus? But once you image, it becomes really clear. Atherectomy, and this is usually not in the setting of STEMI, but when we find calcium deposits in the plaque, that's usually trouble because it really impedes the delivery of balloon and stents across the lesion. And even if we can get a balloon across the lesion, the balloon is non-dilatable, so you can see this hourglass kind of appearance. And so we don't want to deploy a stent in a lesion that looks like this, because the stent's going to look exactly like this. And the stent's going to either thrombose here or restenose within a very short time. And the other thing that calcium could do is when we try and inflate this balloon, the calcium could literally poke this balloon and burst it. When that happens, it really shatters the lining of the artery. It could damage the artery, induces a lot of tears. It could perforate the artery, and that's really never a good thing. It's more commonly encountered in non-STEMI or unstable angina, as opposed to STEMI. STEMI is usually clot. It's usually very fresh. But when we occasionally see it, you need to drill that calcium down, create a path so that the balloons can expand normally. And so rotational atherectomy is essentially a drill bit with diamond studs on it. It rotates about 160 to 180,000 times a minute. And as it goes through the lesion, areas that are resistant get drilled through. Areas that are soft kind of move away. And so there's like differential kind of drilling, so you're not drilling normal segments. And so this essentially is what it looks like. Not sure if it's going to play, but. And so this is an angiogram where we were really having trouble dilating one of the spots here in the middle. And so essentially used a drill bit like this. It has all these diamond studs that essentially chisel out the calcium. And you just basically peck through until it finally goes through there. And that essentially just creates a path for balloons to go through. And none of these procedures are safe or without risk. Most of them are safe, but none of them are without risk. And the two most common complications are dissection and perforation. And so dissection essentially is a tear within the artery. Here I'm not sure if this is going to play, but so essentially what we see is this two layers. I think it's just the videos are really choppy, but there are two layers like a train track that you see up here. And essentially what's happened is that this catheter that was sitting in the artery essentially pokes through, creates a little tear, and as blood flows through, this tear becomes bigger and bigger. It's like a door that's kind of closed but not completely closed, and as wind blows through, the door becomes more and more open, up to a time when it completely shuts down, or the tear flap completely moves over the other side and shuts the artery with clot forming on the other side. So essentially that's what happened here. A tear up here propagated all the way down here. Fortunately, the equipment was still in the right place. We could get a balloon through, and balloon up here essentially move the flap over to the other side and then stent against it. And that usually reestablishes flow. The other big complication is a perforation. I don't think this is going to play. But whenever we see, these are the patient's fingers. Whenever we see patient's fingers on the chest, it's usually never a good thing because they're having pain. Not sure it's going to play, but so this is kind of a raw image, but you can see when we inject down here, you can see this puff of kind of smoke. And this is essentially X-ray dye that's going out into the pericardium. Patients can get really unstable quickly because blood's flowing out of the heart into the pericardial space. And in that case, what happened is essentially there was a wire that was going down the artery. The wire went into a small branch, poked through that branch, and then allowed blood to flow out into the pericardial space. This patient had to go to the OR to get that artery ligated. And then lastly, mechanical support has evolved in PCI. There's a lot of techniques or a lot of equipment that's available. The intra-aortic balloon pump is still the most commonly used mechanical circulatory support device in the cath lab. It's usually put in by femoral access, particularly if it's an emergency. Here at Duke, I think they have a way of putting it into the axillary artery, but usually that's not done under emergency situations. Essentially what it does is it reduces the resistance against which the heart has to pump. It's connected to a console, and essentially a fiber optic cable up here is able to detect when the heart is in diastole. So when the heart relaxes, the balloon inflates, essentially creates this column of blood, which is able to push blood into the coronary. And then when the balloon suddenly deflates, it's like creating a vacuum and suddenly reduces the pressure in the aorta, and the heart essentially has to pump against less pressure during systole. And so it essentially inflates and deflates during systole and diastole. And this is kind of what it looks like. Not sure it's going to play, but essentially I think it's in the corner here. This image is not going to play, but essentially it's a helium pump that inflates and deflates with systole and diastole. So it comes in 3 sizes. It essentially depends on the volume of helium in there. We usually put it depending on the size of the patient. Yeah, thank you.
So if the patients can get the medical therapy on the way to the hospital and then they can still get it when they get there, why wouldn't everybody get the medical therapy first?
So, thrombolysis pre-hospital is only in a few places in North America. And I think the concern is the litigation that's associated, one, with the administration of pre-hospital medication by EMS, especially in the United States. So this thrombolysis is it's a clot buster. It could be associated with bleeding, and you could get bleeding like within the brain. So in the STREAM trial, they found that the bleeding rates were somewhere between 0.5% and 1%. Intracranial bleeds were between 0.5% and 1%. And so I think the litigation that's associated with somebody else administering a clot buster that could potentially induce bleeding has kind of dissuaded pre-hospital use of thrombolysis, at least here in the United States. But in Canada, where really that's the only option for patients who are out that far, from about 2006, we've routinely used pre-hospital thrombolysis administered by EMS after speaking to somebody on the phone.
Anybody else?
I was wondering if the patient has chest pain and they come in and you see some stenosis like due to a plaque or the calcium or whatever, do you use any of these interventions if there isn't a kind of like a clot, like a thrombosis?
Yeah, so if there's thrombus, so aspiration really we don't, at least since the publication of the total trial of last year, the rates of aspiration thrombectomy have gone down. And generally what we would do if you find some thrombus that's, really it's not a lot of thrombus, there is some thrombus, you could essentially balloon that. A lot of it gets plastered against the wall, a lot of it gets embolized distally, and the body kind of dissolves that over time. But if we just find a stenosis, really no clot, then essentially we would just balloon and stent. So that's kind of the default balloon followed by stent. Sometimes there is some thought that in STEMI, where there could potentially be a lot of thrombus, that the less we manipulate inside the artery, the better. So some people, once we get the wire passed, would just put a stent instead of putting a balloon first and inflating the balloon, because by inflating a balloon, you're kind of manipulating that thrombus, and you have a higher chance that you could plug up all the distal microcirculation. And so try and not manipulate the artery as much, just put in a stent directly, so you have just one inflation and come out. But really that's not, it's kind of practice dependent. There's really no evidence of one way or the other. So many people would gently balloon, create a path, and then put a stent in.
Hi. You highlighted the importance of timing from acute onset of the symptom to a primary PCI. In some of our analysis, I've noticed that there are some elective PCI. So what is the timing there, how it is decided?
So for elective...
And who are those actually receive the elective ones?
Right, so for elective, those would be people really not any of these. So those are patients who would present with stable angina. They have a stenosis that's progressed over time. And so you have a stable plaque, but the plaque's kind of grown over time. So if that was the artery lumen, over time it gets smaller and smaller. Those people, when they exert, will get symptoms. When they rest, there's really not normal flow, but there's enough flow that they do not get symptoms at rest. But when the demand increases, that stenosis does not allow enough blood to flow through, and those patients would get symptoms. So those would be stable angina, and those patients would then be referred for elective PCI. So really, time to treatment in those patients is not really as important because the artery is open at rest, there's enough flow. It's just when they exert that increased demand does not allow enough blood flow through that stenosis. So time to treatment really does not matter as much for patients with stable angina, but for patients with STEMI in particular, where the artery is completely occluded, 100% occluded, there's really no blood flowing down to the myocardium, then time to open that artery becomes critical. So really, it's in the STEMI setting, and sometimes, in the high-risk non-STEMI setting, where people are getting a lot of ECG changes, and we know that that artery may be completely being blocked off, but then the body breaks down the clot, some channel opens up, blood flow is restored, and then more clot forms, and the artery is completely occluded. So you may get patients who are really dynamic, and those are high-risk non-STEMIs. Those need to be cath fairly quickly. But STEMI, for sure, we know that time to treatment is like key.
I'm wondering, were there any ethical discussions? I think it was the STREAM trial, right? The one that it was in patients who were going to arrive late. Were there any discussions about the ethical considerations of withholding the use of a thrombolytic therapy, given the curves you showed us are from like the early 2000s, like Bernie Gersh's curve? So you know that that myocardium is dying if you wait too long. It seems like that it would be difficult to enroll patients into a trial like that if you're withholding the thrombolytic therapy.
So for, the Bernie Gersh curve was about 2005, slightly earlier than that. And he says, the times, and it was a hypothetical construct. So he say when he came over, he said essentially that curve, the theory behind that curve was to try and identify really how we can move patients from one point to the other. The timelines, whether it's 3 hours or 4 hours, may not be completely accurate, but I think where the curves start to inflect, it's maybe about 6 hours from what he thinks. It may not be 4 hours as he had initially supposed, but I think 3 hours is still fairly early. So if people present within 3 hours, that's fairly early presenting. And so I don't think there would be really an ethical consideration as to whether they should get, because there's clearly equipoise, whether those patients should get lytic or those patients should come for primary PCI. But if, for sure, once you pass that 3-hour point, then you know that you are going to be in that lower part of the curve, that any further delay, you're going to lose a lot of myocardium. And so past 3 hours, we know that those patients should generally probably go for primary PCI because the clot has had enough time to organize that the clot buster really won't open those arteries up. And so what we do, if our patients come symptom onset, like the total ischemic time is, say, 5 hours, we would bring that patient for primary PCI, essentially not put that patient at risk of a major bleed with a thrombolytic, because we know that in 5 hours that clot has really organized and that a clot buster really won't open up that clot. So if a patient comes in 5 hours, that's fairly late. A patient should probably go for primary PCI. But if a patient presents within 2 hours, we know that clot is fresh, it's going to really break down with that thrombolytic. So kind of 3 hours is based on both that Bernie Gersh kind of curve, but also I think their previous experience.
That's okay.
How you doing? Thank you for your presentation. It was really informative. So one of the questions I have, so a lot of times now in this cardiovascular space, we see these composite endpoints being proposed, and they tend to include revascularization in this endpoint a lot of time because the hard endpoints that we really care about are just so rare.
That's right.
But in some of these populations, for example, if you have like a stable chest pain population where you may have patients who do have some degree of stenosis, but they don't necessarily have a 100% occlusion. I've always wondered, what are the most important factors that really go into making that decision to stent a patient who does not necessarily have a complete occlusion, but the reality is that now this patient is going to be considered as a patient who had an event, even though their disease is probably not as severe as what we would want to measure with some of the other components of that composite.
Yeah, no, I agree. I mean, the reason why, and especially need for repeat revasc or admission for unstable angina is kind of included in the endpoint is because the other 3 or the other 2 endpoints are rare, and try and populate that primary outcome, you'd include a softer endpoint. And that's been an area of controversy, especially in trials that compare CABG versus PCI, for the last maybe 5 years, and then FAME2, which was a physiologic measurement of a stenosis, where they say, okay, what we're going to do is a patient presents with a stenosis of, say, between 50 and 70%. We're going to put this wire down, and we're going to see if that stenosis that we're not really sure is significant or not. And if it is significant, we're going to stent it, or we're going to randomize to routine care. And so patients who went home on routine care had an angiogram that said, oh, hey, you've got a 60% stenosis, or you've got a 70% stenosis. We're going to send you home because we're really not sure whether this needs to be stented or not. And those patients came back within a month to the emergency complaining of chest pain because you know you have a 70% stenosis. Any kind of exertion you do, I mean, your threshold or your sensitivity is high. I know I have a 70% stenosis, and the doctors decided to treat me with medical therapy. And so really including that as an endpoint in your trial, and that's what was the criticism of FAME2, is that they included hospitalizations or rehospitalizations for unstable angina as their endpoint, which is what drove the primary endpoint, not really death or re-MI. So I agree with, I totally agree with you that, including some of those softer endpoints within a clinical trial may not be the right thing to do. And that there are techniques available if you have an indeterminate stenosis. So you have, stenosis of between 50 and 70 to really assess whether that is flow limiting or not. So you could use measures like an FFR, or you could use intravascular imaging and draw out the area of tightest stenosis and compare that to the normal segment, and that essentially gives you an accurate, degree of stenosis.
Anybody else? Thank you so much.
Yeah,
This has
thanks.
been wonderful. Oh, everybody, please, please, please fill out one of the forms before you leave. If you need pens, there's forms up here and back there. Thanks.
Thank you.